It's started now. There we go. Okay, and I'm very happy to introduce Lucy and Emma, who are hand therapists from Northampton General Hospital. Over to you guys, and I'll work through the slides for you.
Thank you.
Thanks. Hi, my name is Lucy. I'm one of the hand therapists team lead. Emma and I job share effectively at Northampton General Hospital.
I'm Emma, again, one of the team leads at Northampton. So, hello.
Next slide, please, Sam. Thank you. So we work at, as I said, Northampton General Hospital, which is we work as an outpatient department, but it's based within the acute hospital setting. Next slide.
So what is hand therapy? We found a nice little quote from St George's NHS Trust. So hand therapy is the art and science of evaluating and treating injuries and conditions of the upper limb. We use a number of therapeutic interventions to help return a person to their highest level of function. Next slide, please.
So how our service runs is that, as we said, Emma and I we're both Band 7 team leads. Effectively, we job share, and then our counterpart, we have another Band 7 who's a clinical specialist, and then we have 3 senior hand therapists who are Band 6, and we've recently started up a rotational Band 5 position within the department, which rotates within occupational therapy. So our team, we work generically. We can either be occupational therapists or physiotherapists by background or qualification, and then specialise in hands. It kind of happens at the moment that we all tend to be occupational therapists, but we actually generally prefer to have a little bit of a mix. As I said earlier, we're an outpatient department, so we kind of operate Monday to Friday, a 9 to 5 type service, but we are based in the busy kind of acute hospital. We, although we're kind of a relatively small department, we are busy. We receive about 125 new referrals each month. And those referrals are in-house referrals, so we only accept from plastic surgery at Northampton General, trauma and orthopaedic at the General, and virtual fracture clinic. So those are patients that have been to A&E. The trauma and orthopaedic consultants look at their X-ray, but they don't physically assess the person, but they will redirect their care to hand therapy. Next slide, please.
So we treat loads and loads of different conditions. So under the umbrella of the trauma and orthopaedics, we might see hand and wrist fractures, finger fractures, soft tissue injuries like ligament injuries. We might see people after having surgery for carpal tunnel decompression or having a trigger finger release, Dupuytren's fasciectomy. We see joint replacement, so in fingers, thumbs, wrists, trapeziectomies and mallet fingers. There's loads more, but there's just a few that we treat. Next slide, please.
And then how the plastic surgery split in our service works is that they generally don't treat bony injuries, but they would treat more soft tissue damage. So from plastics, we receive referrals for flexor and extensor tendons. And they can be kind of one single tendon repair or quite complex multi tendon repairs. Also tendon transfers, crush injuries, degloving injuries, nerve injuries, repairs, and generally scar management as well. And that doesn't need to be exclusively to the hand. It can be anywhere on the body. We will manage that as hand therapists, which is a bit of an abstract concept often, but we do. Next slide, please.
So we use loads of different treatment modalities. So splinting is one of the main things that we do. So the picture there is of a flexor hood for somebody that's had a flexor tendon injury, but we do splinting for all parts of the hand and wrist. We might prescribe exercises, so to try and restore movement and functional exercises, so using bits of equipment, maybe jars or kettles, trying to get people back to the activities of daily living that they need to do. Lots of education so that people understand the injury that they've sustained and why we might be asking them to do or not do particular things with their hand. We use ultrasound treatment, so that's really good for treating soft tissue injuries. We manage edema, so when the hand is very swollen, we might look at gloves or massage or elevating the hand to try and get the swelling down. Scar management, so again, massage, silicone, garments, all sorts of different things we do for that. We've recently started to offer acupuncture treatment, so we can just do it for the hand, and it's mostly to manage sort of chronic type pains more than anything else. We do wound care, so that might be post-trauma or post-surgical interventions, and we can measure and order for pressure garments for scarring and swelling. Next slide, please.
So our service see patients post-operatively frequently, and we try to generally see these patients 3 to 5 days post-surgery. So they're quite quick that we see them post-op. But we often see quite a lot of post-operative complications, which obviously have a long-term impact into how we're able to rehabilitate someone and the duration in which it takes for us to and the patient to be able to achieve maximum function. Some of the kind of common complications that we see as a lot of excess edema, which you can see in that picture. So the hand on the left is significantly more swollen than that on the right. Infection, again, that's evident in that picture where there's quite redness, there's a lot of swelling, that can be pus and that needs treating, but it can be quite a detriment to the potential surgery that they've had, and sometimes it can completely damage the surgery that they have had. Slow wound healing generally is a complication that we see sometimes in patients with other health conditions such as diabetes, or just general aging population can slow down wound healing. CRPS, which is chronic regional pain syndrome, that can be a complication that we see and we have to treat, which really has such a significant impact on the rehabilitation and long-term outcome of patients' therapy. General stiffness, it can be as a result of all the things that I've just said, but also in isolation occasionally as well. And then other barriers to compliance for the patient. If some people have significant work demands which they're unable to compromise, then that can be kind of cause some post-op complications as well. And these are all significant challenges for us in hand therapy that we have to work alongside and manage to be able to achieve the best outcome with the patient. Next slide, please.
So the project that we undertook for the Green Team competition was to have a look at the plastics operative trauma pathway. So we've just listed roughly what the process was prior to actually making any change. So in order, patients obviously injure themselves, they present themselves to A&E. A&E assess them, see what the problem might be, and then refer them to the plastics trauma clinic. The patient comes into the next available trauma clinic, which is normally same day, next day. It's not normally more than a couple of days. The consultant will assess, decide whether or not they need to have surgery, consent the patient and book the surgery. And then the patient goes home. The consultants refer patient to hand therapy via one of our computer systems called ICE. We print the referral off, and then every day the referrals are triaged. So we'll put all the information into a database and decide how quickly the patient needs to be seen, which is mostly kind of evidence-based. So we get a lot of that information from the BSSH or from hand therapy articles and journals and things like that. So the senior staff allocate an appointment based on the clinical need and appointment availability. So we'll have a look through the diary, make sure we can see the patient as quickly as possible. We usually want to see them for post-op plastics patients between 3 and 5 days after they've had their surgery. we hand the referral over to the admin team, and they will either repeatedly try and telephone the patient until they've made contact, or if they can't do that, then an appointment letter will be sent out. And that's the process before we started the project. Next slide, please.
So kind of the issues we were finding with this process was really that patients had a really poor understanding of hand therapy and the post-operative care and the timescales that would be received in. I think as a general rule, hand therapy is poorly understood generally, but we were finding that patients had no idea what that entailed. And I think they generally thought maybe we'd just give them some exercises, and obviously that they would be in a post-op cast, often plaster of Paris. So, they can't be doing exercises. They haven't even seen a doctor yet. So people were quite concerned to be coming to hand therapy so soon post-operatively. And as a result, we were noticing that patients were quite anxious. We were having a lot of questions come via the admin team about why they needed seeing so quickly. And from a practical logistical point of view, it was really difficult for us to allocate appointments within the kind of general 3 to 5 days post-operative timescale. A lot of the plastics trauma list was done on a Thursday afternoon. So when we were triaging the referral on a Friday, we then had to take into account the 2 days of the weekend. It quickly became challenging to get them in time. Admin really struggled to make contact with this patient group also. We would ask them to repeatedly contact the patient via telephone. And if they didn't have a number, they'd often have to chase around lots of different systems and even going to the GP for the most up-to-date number, which obviously all took time. If they weren't able to make contact by the telephone, they were sending a letter, but obviously this takes time. Our trust now send all their letters second class, so there was no way that this patient group would therefore be seen within the timescale that they required, and that was already then causing post-op challenges for us. And as a result of all this, we were holding those appointments for patients, and there was a lot of wasted appointments. So although the patient wasn't technically DNAing, we were allocating them time that was then being clinically wasted. And then we were noticing a lot of complications at the first appointment due to the delay in care and poor patient understanding and education. Next slide, please.
So as part of the project, we decided to change the process. So the bits that are in green are the things that didn't change. So the first 4 steps of that didn't change. But once the patient had been seen and assessed in the trauma clinic by the consultant, rather than being sent home, they were sent to the hand therapy department. And then they were just asked to wait in the hand therapy department until a hand therapist was available to see them. So they didn't normally wait too long. It was roughly around 15 minutes. And then we had time then to discuss what the hand therapy process was with the patient, answer any questions they might have, just kind of setting any expectations. We could give them handouts about what they needed to be doing between now and when they had their appointment, such as like keeping their hand elevated, trying to maybe keep their fingers moving a tiny little bit within the dressing that they had, and showing them the technique for ensuring that their hand is elevated enough so that they're not coming back with too much swelling to that next appointment. We would schedule them an appointment, so they would leave with an appointment and knowing where the hand therapy department was, and we would complete our outcome measure. So we use a quick dash outcome measure, and just to save time at the first appointment, that was completed with the patient when they came down just for the quick hand therapy visit. And we just discussed with them any complications, so talked about any what the signs and symptoms of an infection might look like, so that if they did have any concerns in between having their surgery and our appointment, they could get in contact if they needed to. The consultants continued to refer, because obviously they have an idea of what they might do in the surgery, but actually once you've opened the patient up, they might actually do something different. So it was still important for them to do the surgery and then send the referral and the op note so that we were treating the patient from the correct information. And then the referral then didn't need any further actioning, so the admin team didn't need to ring the patient or send out any letters, so that saved them a considerable amount of time and effort. Next slide, please.
So, I mean, it was a really quite a small process change that we made, but we looked at kind of how, like, the different ways that we could measure the change and how effective that process was. So we looked at a patient's journey. So what we chose to do is we selected a month of the first process prior to this process change, and we took a month sample of patients and followed their whole journey throughout hand therapy. And then we did the same with a month's sample of patients after the process change and followed their journey throughout hand therapy. And we looked at the total appointments that those patients had. So that was under hand therapy, but also for the consultants, for the dressings nurses, and anyone else that they may have had additional appointments with in the hospital. The duration in which their care lasted under hand therapy. We looked at the number of DNAs did not attend to their appointments, because we noticed that this patient group in hand therapy had a significantly high DNA rate. We also looked at the breach to the target times that we saw them in hand therapy. So generally, it was generally a 3 to 5 day target. Some surgeries are a little bit different, but as a generalisation. So we looked at how many patients met that 3 to 5 days target before and after the process change. We also costed the total dressing spend. So if there was a difference of that. And importantly, we got patient feedback of their experience of that service and how it was for them. Next slide, please.
So we had a look at the environmental sustainability, and we looked at the PSSRU, and that's how we kind of worked out what the CO2 emission factors would be for an outpatient appointment, which included travel, equipment, and all of those things that we might use during the appointment. We looked at the CO2 savings from the reduced dressings, and we used an emission factor for equipment of 0.46 kilograms of CO2, and that came from the Greener NHS database. And the CO2 reduction was translated into miles driven using an emission factor of 0.3386 kilograms of CO2 per mile driven in an average car. And that was from the UK government greenhouse gas reporting conversion factors. Next slide, please.
So kind of further on with this, the consultant-led appointments, we took the national schedule for 21-22, and that was costed at £184 an appointment. And then there wasn't a hand therapy specific appointment cost, but we, as we're kind of as a team, occupational therapists or physiotherapists by background, we use that and of a band kind of 50-50 between a 6 and a 7, and we averaged out that cost. So that was a range between, it worked out as an average of £13.75 per appointment in hand therapy. And we used that same cost for a DNA because it effectively was a wasted appointment. And then we costed dressings based on what we were charged in the department. And we kind of went back through retrospectively through the notes. I did a notes audit about what dressings we used. And that's how we used found a cost for that. Next slide, please.
So the social sustainability was measured by getting feedback from patients. So we regularly in the department do the friends and family feedback. So we were able to look at the pre and post change of that. And then we asked staff, so we got feedback from the admin staff, the hand therapy staff, nursing staff and consultants to see whether or not, what impact the change had for them as departments as well. Next slide, please.
So these were the results that we got based on that kind of 1 month sampling pre and post change, but looking at that whole patient journey for that sample. So this small process change basically saved us 45 hand therapy appointments, which worked out to be a 43.6% reduction. So it was quite a significant amount of appointments that we were able to save clinically with no reduction to patient outcome. We looked at other departments' appointments, reduction of 33 other outpatient appointments. So this was a mix of dressings and consultants, but again, that was 54.5% reduction. So again, another significant saving to the bigger MDT team. When we looked at the DNA rate for this patient group, that was a reduction of 11%. And we also had a reduction of 33% breaching the target time. That's kind of generally that 3 to 5 days post-op. So we were able to see many more patients within the timescale that they clinically required. We also, as I said, looked at the average time under hand therapy, which in the first patient group was 78.3 days, which was reduced down to 61.7 days. So again, a 21.2 reduction, which was great. We made some cost savings with dressings because of the reduction in complications. The wounds were less complex, so they required less dressings and less complex dressings. So that saved us £26 and 45 pence, and an average reduction of 43% in stock costs generally. So that would be other things that treatment modalities that us as hand therapists would give out. So kind of off the shelf splints or putty or lots of different modalities that we might use in hand therapy. Next slide, please.
So the environmental outcome was also quite surprising. So the reduction in 33 appointments with the consultants and dressing teams was a reduction in 726 kilograms of CO2. And the 45 appointments that were saved with hand therapy was a reduction in 990 kilograms of CO2. So there was a total saving of 1,716 kilograms of CO2 for the 10 patients that we followed through their journey, which was an average saving of 171.6 kilograms per patient of CO2. We had a look at, with an average of 11 post-op plastic patients referred to the service every month. We could look at the anticipated annual savings, and that was likely to be around 22,651 kilograms of CO2, which is the equivalent of driving 66,896 miles in an average car. Next slide, please.
So in terms of kind of costing of the appointments for the trust, the reduction in 33 consultant appointments saved £6,072. And when we upscaled that based on the number of referrals we averagely receive to make that an annual saving of approximately £80,150. Similarly processed to hand therapy, that equated to an annual saving of £8,168 kind of predicted based on our numbers. DNAs was a 165 annual pound saving, and the stock saving with a reduction of 43% in stock, it was predicted to save us about £350 annually. So when we totaled all those savings up over upscaling the project for a year, it was predicted that this would save our trust about £88,830. Next slide, please.
So we had a look at the feedback, patient feedback, and from staff as well. So we had a look at the friends and family results that we'd got prior to doing the process change, and 92% of the patients that we surveyed said that our service was very good, and 8% said it was good. And then once we'd had the process change, we looked at the friends and family results again, and they had gone up. So we've got 97.5% of our patients felt the service was very good, and 2.5% said good. We asked patients to tell us whether or not it was important for us to be looking at sustainable healthcare. And one patient commented that everyone should be aware of environmental impact, and any effort to be sustainable is a good effort. We had feedback from the consultants, so they thanked us for the excellent work, and the consultant that gave this feedback had discussed it with his appraiser, the results of the audit, and recommended that we register the audit with the Trust, Quality and Effectiveness Group. Admin were very pleased with the changes, so it saved them quite a significant amount of work, and they really appreciated the change in the system because it took quite a lot of pressure off them. And the hand therapists that were involved in the project, they liked the new pathway. I think some of us found it a little bit stressful when we had patients just waiting in the waiting room, and we already had quite full diaries, but actually the benefits to the patients, and obviously sustainability and economically as well, outweighed any of the difficulties that we had in rolling out the project. Next slide, please.
So when we looked at this project overall and kind of the continuation of this project, the difficulties that we've come across is, as Emma said, that it can be difficult to see these patients. So often they're relatively low numbers, and they'll kind of trickle down to the department within the morning when trauma clinic is being run. So it generally works quite well. There is some days where you do have a higher number of these patients, and there is more of an influx of them. It can be quite stressful because we all have our diaries are clinically booked back to back. So it can be difficult. It can be a little bit more stressful. But the more confident we've got with the information that we're giving, we've supported it with written information for the patient as well. It is becoming much easier. The other thing that we've noticed is as plastics registrars change, rotate, or leave the trust, the education and engagement of those registrars is really significant to this project. As soon as we don't have their buy-in and their support, the whole thing fails. They aren't being sent down to hand therapy after the end of their trauma clinic appointment, and then this whole process doesn't happen. So education with the registrars when they rotate is really like an ongoing, continuous process that we are really trying to engage significantly with. And then also generally staff training. So in hand therapy, when we have staff change or additional staff come to us, we're just going through the process, the information that we're giving, to making sure that it's as standardized as possible. And that's kind of an ongoing thing that we're offering. Next slide, please.
So in conclusion, we were really surprised with the outcomes, so the really positive outcomes of saving money, sustainability, saving all of the kilograms of CO2 for such a minor change. It didn't have a huge impact on the department. There's no financial implication to us kind of rolling it out, and there isn't any financial implication to it sort of going forward. So in the future, we would like to roll this process out with the trauma and orthopaedic team with their trauma patients, which should see us, saving even more appointments and making the patient journey even better for a greater number of our patient group. Next slide, please. I think that's it.
Yeah, we're at the end. Amazing work, guys. Thank you so much. I mean, what an incredible project. I can't believe you saved like nearly £90,000 annually. That's incredible. Yeah, absolutely amazing. I'm just going to open up the chat and see if there were any questions that got popped in. If anyone does want to raise a hand and ask a question, now would be the time. But I wanted to ask a quick question, if that's okay. Did either of you guys do any sort of training in sustainability or QI or anything before you ran the project, or was it kind of learning as you went?
No, neither of us did.
Support.
Really?
Wow.
Wow.
Ellis signed us up to the Green Team competition. So they were fantastic. They really helped us. I think we would have done a project very similar to this anyway, but we wouldn't have had that consideration, that slant on it. And that's really where all the how surprised we were about what the significant benefits were. Really, normally, I think if we make a service improvement project, we tend just to look at how it affects the department